Well, the cost is certainly a shocker. We are today the world's most expensive therapy. I'm on a panel this afternoon, turns out, with the previous world's most expensive therapy and the one before that. So there's three of us that have had that title. And it is a shocker because our health system is used to paying for, a pill a month or an infusion a month or whatever that cycle is for whatever it is that you have, or ongoing care that again comes month by month or week by week. So the system is shocked by this, and it is adjusting. It is understanding this whole message of value, which is what they really want in all of the system. If they're paying for $1,000 a week, that's $50,000 a year. That's $500,000 over 10 years, or some of these therapies are several $100,000 a year. The system's used to that. The system's used to budgeting that way. When we get into multi-million-dollar therapies, the system chokes, and it's a one-time therapy, so it's a one-time payment. But biopharma is looking at creative payment agreements. Some of them are value-based agreements with some sort of a rebate or a refund. If the therapy doesn't work, or it doesn't work as well as we thought it would, then there's some sort of a reimbursement that comes back to the institution or whoever paid for that drug. So the pharma companies are confident enough that they're providing some insurance or guarantee that their therapy will work or they will do something. But the system is also looking at that as well. And we have public payers, we have private payers. Medicaid is obligated to pay, but again, they have to figure out how to do that. So their way of not skirting around the payment, but the insurance denial, the Medicaid denial, is to challenge medical necessity. Is this the right therapy for that patient? And they're not really equipped to do that, not at this scale. So they have experts, but the experts may not be experts in this piece of, ours is a neurological condition, in this piece of rare neurological disease. It might be a more general neurologist, or in some cases not even a neurologist that is their expert. So we're having to help them in the system on that part. On the private side, I've learned a lot about this, right? Because we just assume, I always assumed that when I had a bill, I might get a denial from the insurance, and I had to go back and argue that and appeal that and so on. And I've generally been successful with that because we're not an abuser of the system. But it turns out that a lot of companies in America, there's very, very large companies. On the other side of the convention center is an auto show. A lot of big companies over there and so on. They have fully insured insurance plans where the insurance company basically has to cover all but anything. But that's not the case with most American employers, which are small and medium-sized businesses. There's been a shift towards being self-insured, which means that an insurance company is managing the company's money, but they're really writing checks out of the company's checkbook. And it turns out that those self-insured companies, in order to keep the cost down, or as different vendors, insurance companies come in and want to sell their product, or displace somebody else's product, that one of the things that they're doing is they're setting up exclusions for higher priced therapies. Not million-dollar therapies. These could be therapies that are $50,000 and above, which a lot of my peers here, a transplant is a several $100,000 therapy, and that's a common therapy. Enzyme replacement therapies are in the hundreds of $1,000s per year. So they have these cutoffs that say we don't cover that. So the self-insured employer can buy what they call a stop-loss policy, which says, hey, when you have an extraordinary loss, then it goes into a different insurance pool. So the insurance company is insuring themselves, or in this case, they're adding on a formal, this is really expensive, a formal policy to cover that. But price competitiveness, people, some of the companies come in and say, we can save you 5% or 10% on your insurance. And this is important to small and medium-sized business. They can look at those dollars and say, I could do something, I could hire another employee, or I could get this project done. And they don't realize that it's not just normal competition. Bananas are 99 cents a pound versus 89 cents a pound. But they could come in and just say, oh, it's the same product, but it's less expensive. But they don't realize these extraordinary conditions that aren't covered. So that's something that we're now also getting educated on, and starting, actually probably will engage with some other folks on some legislative initiatives to say, at least you need to be transparent. Insurance company A, when you're offering to facilitate a self-insured employer, most employees don't know that their insurers are self-insured. So that's another thing. But we want full disclosure, and perhaps some minimum requirements, or maybe a requirement that there is a stop-loss policy that says in case of catastrophic loss. When we see big hurricanes, or we see floods or fires out west, those insurance companies in many cases are also they're in these major catastrophic event insurance pools. So folks on the East Coast that have the insurance for hurricanes, if there's not a handful of hurricanes in a year, but there is a big fire, some of that secondary insurance, that stop-loss insurance, might be moving from the East Coast to the West Coast, and vice versa. Of course, we have a challenge now that we're starting to see those things happen, on both coasts at the same time, and now that's sucking from the stop-loss pool. But that's a different challenge we need to, and the federal government steps in on some of that as well. And that might be some of what happens with rare disease, because these diseases are rare, and so you can't predict. One of the things that insurance companies want more than anything else is predictability, consistency, because then they can do, you've heard of the guys that do the actuaries. So the actuaries, they look at these statistics and the averages and the trends and so on, and that's how they can figure out, this is how much insurance we're going to pay out, therefore this is how much we need to charge, this is the overhead to manage it, and so on. And they love predictability, but when you're talking about a company that might have 100 or 200 or even 500 employees, they don't know if an MLD patient's going to show up, and so they can't plan for that. They don't know if another patient. There's over 10,000 rare diseases. Most of us don't have therapies, but more and more do, and they can't predict when those patients are going to show up. Maybe 10 years from now, we'll have enough therapies that there'll be, at least across rare diseases, there'll be some continuity in that, but they don't have that today. So I appreciate the challenge that they're having, and frankly, it's the same thing on the public payers too, and the Medicares and the Medicaids. They can't do the predicting at this point either, but they do have Uncle Sam back in DC that often comes to their rescue if need be, but they need to they want predictability as well. They don't have infinite budgets.